Hello everyone. I welcome you all in this live webinar on top microbiology stewardship papers uh, today. So let me introduce our guest speaker. So ladies and gentlemen, our esteemed guests and distinguished colleagues, it is my privilege to introduce our esteemed guest today, Dr. Andrea Pinzi, with a profound background in clinical microbiology. Dr. Prinzi has dedicated over 12 years as a bench microbiologist at Children's Hospital, Colorado, contributing significantly to the field. Her academic journey is marked by a master's in public health with an emphasis in epidemiology earned in 2014. Following this, she has played a pivotal role in designing and imparting microbiology focused programs to clinical providers at University of Colorado Anschutz Medical Campus. In the early months of 2022, Dr. Prinzi achieved a significant milestone, obtaining her PhD in clinical and translational sciences. Her research has notably centered around antimicrobial and diagnostic stewardship, specifically focusing on pneumonia diagnostics in mechanically ventilated patients. Beyond her extensive and clinical and scientific endeavors, Dr. Andrea Pinzi is a prominent figure in clinical and public health community, serving as the clinical and public health community leader for the American Society for Microbiology Councils on Microbial Sciences, and as a Pediatric Infectious Disease Society Global Stewardship Committee member. She continues to shape and advances the realms of microbiology. Please join me in welcoming Dr. Andrea Pinzi, a distinguished expert whose contributions have significantly impacted both the scientific and healthcare communities. Thank you.
Thank
So
you
the
so
mic is
much.
all yours.
Thank you. Thank you so much. Good morning, good evening, everyone. I am absolutely delighted to be here and I really appreciate the offer. And I'm excited today to take a deep dive into the top papers in diagnostic stewardship and microbiology from 2023. There is a lot to cover today, so I'm going to jump right in. I'm going to turn off my video just to make sure that I don't have any bandwidth challenges here. And we will get started. My primary disclaimer is that I'm a medical science liaison for U.S. Medical Affairs at bioMérieux. And I'm going to start with diagnostic stewardship papers first. And I just want to make a quick comment about choosing these studies. So I have top papers on this slide, but really, I think choosing the best studies of the year or top papers is fairly subjective. I think it really depends on where you're working, what your practice setting is, what your area of research interest is. So it can be kind of hard to pick the best ones. I went ahead and tried to target papers that really focus on hot areas of interest or major topic areas in diagnostic stewardship right now, but also tried to be broad and include studies that include different types of practices, different settings, and different approaches. So hopefully at least some of these speak to you and you find them to be relevant, but I certainly am not going to be able to include all of them, as just a ton of really great studies came out this year in microbiology and diagnostic stewardship. You're going to see some honorable mention slides in this presentation today. These are studies that I'm not going to take a really deep dive into, but that I want to at least mention and make sure that you're aware of. For future reference, you can look these up and read them in your own time. These two papers here came out from Shea this year. These were both published in Infection Control and Hospital Epidemiology, or ICHE, we call it. Both of these are really great papers for providing a background on diagnostic and antimicrobial stewardship and where we are today. So if you're new to diagnostic stewardship, these are really great papers to read to get familiar with what's going on in the field. But even if you've been doing diagnostic stewardship, this is a great update about where we are now. The top paper there really covers a modern review of diagnostic stewardship, current approaches, needs. It focuses on the importance of broadening our reach and measuring outcomes, but also assessing harm or unintended consequences of any of the stewardship interventions that we put into place. And it also talks about using implementation science and socio-behavioral approaches in our research. The bottom paper there is really unique in that it ties together diagnostic and antimicrobial stewardship through the use of examples. So it provides several clinical vignettes, or they call them clinical moments or examples of how diagnostic and antimicrobial stewardship are used together in clinical practice and what that looks like. So if you get some time, I highly recommend taking a look at these, as they're really great overview papers for diagnostic stewardship. The next three I want to mention are also honorable mention, but I definitely wanted to make sure I tell you about them. These really focus on implementation science and context for implementation. So the top study up there is led by Dr. Anna Samuels from Johns Hopkins University, and it's called A Survey of Pediatric Intensive Care Unit Clinician Practices and Perceptions Regarding Respiratory Cultures in the Evaluation of Ventilator-Associated Infections. If you're familiar at all with the Bright Star Collaborative, this is a large pediatric diagnostic stewardship initiative focused on blood culture use. And this particular study is a branch of that focuses on respiratory cultures. And Dr. Samuels does a lot of work in pediatric diagnostic stewardship for respiratory cultures. And this study is really great at identifying context, barriers to implementation, and targets for intervention that can help guide future diagnostic and antimicrobial stewardship initiatives. The study below that does a similar methodology there. That's led by Dr. Kathleen Kiotos at Children's Hospital of Philadelphia, another really fabulous researcher in pediatric diagnostic stewardship. And this study walks through the context for an implementation that they did, and then assessment of outcomes related to their intervention. So it combines mixed methods to really give you a picture of what worked and why it did or did not work. And then the study up in the top right there from Dr. Sonali Advani and Dr. Kimberly Clays is called Behavioral Strategies in Diagnostic Stewardship. And this is really more of a narrative review, but it's an excellent resource for understanding some of the behavioral approaches to diagnostic stewardship. And it does a really good job of highlighting formal implementation science frameworks and models that can be used in stewardship, which I think is really important. And the reason I bring all of these up is because we are starting to see a shift in the field of infectious diseases, microbiology, and stewardship, where we focus a little bit more on implementation science strategies. And the reason for that is because so many of the things we're trying to influence with stewardship are behavioral. And so this is really where I think where the future is headed. You're going to see a lot of mixed methodology, socio-behavioral strategies, implementation strategies. And so it's a good thing to get familiar with, and these papers would be a great resource for understanding that a bit better. So I'm going to start on the first study that I'm going to walk through or take a deeper dive on here, and it's focused on urine cultures. I'm going to do several studies on urine cultures and then move to different specimen types. I've kind of batched them together that way so that we can think about the same concepts as we go along here. This first one was published in Infection Control and Hospital Epidemiology. It comes from Dr. Sonali Advani and team out of Duke University Medical Center. And it's called Optimizing Reflex Urine Cultures Using a Population-Specific Approach to Diagnostic Stewardship. The medical problem that they are looking to address in this study is that urinalysis and urine cultures are very overused, and this usually leads to excessive antimicrobial use and adverse events in patients. Additionally, even centers that use urinalysis to as kind of a screen to reflex to urine cultures, there's no consensus on the parameters that should be used for the urinalysis for reflexing to culture. And so the aim of this study is to identify and validate urinalysis criteria for reflex cultures. This was a retrospective cohort study of 3 North Carolina hospitals and more than 150 outpatient clinic sites. It included all patient encounters with paired urinalysis and cultures between January 1st, 2015 and December 31st, 2020. Their primary outcome of interest is significant bacteriuria, which is considered a culture with 1 or more uropathogens growing at greater than or equal to 100,000 colony-forming units per ml. They evaluated the performance characteristics, so things like sensitivity, specificity, negative predictive value, and positive predictive value of urinalysis parameters like pyuria, leukocyte esterase, nitrite, and bacteria for predicting significant bacteriuria, which is that primary outcome. This is just a graphic of some of the models that they ran. So models 1 through 12 have gray boxes there. The gray boxes represent an OR rule. So that is where they are just testing one parameter against another. And the blue boxes are and rules. So those are where they're combining multiple parameters together and seeing how they work if they combined multiple urinalysis parameters. In total, there were 221,933 encounters that met inclusion for the study. There were over 84,000 outpatient specimens. The absence of leukocyte esterase and pyuria had a high negative predictive value individually. And interestingly, combining parameters did not perform better than leukocyte esterase or pyuria alone in terms of negative predictive value. That high negative predictive value was maintained in males and non-catheterized patients for pyuria when they did a sub-analysis across different patient groups. And this suggested that those populations may be at most benefit of looking for absence of pyuria. The presence of bacteria had a high negative predictive value as well, but the authors note that we really shouldn't be using this since it's impossible to differentiate between infection and contamination on urinalysis alone. So their take-home key takeaways here or conclusions is that absence of leukocyte esterase and pyuria had a high negative predictive value and may be adequate individual criterion for reflex to culture. Reflex urine culture strategies may not be best suited for use in older females or people that have indwelling catheters. Only symptomatic patients should be tested in the first place, and urinalysis parameters in a reflex urine culture should be based on that negative predictive value. They also said that they would recommend that centers take what they've done here and apply it to their local context, validate this against their local data, and see what works for them. But they recommend doing this to really optimize the use of that urinalysis to make sure we're culturing less or only culturing when it's really appropriate. The next study was published in JAMA Internal Medicine. This is led by Dr. Valerie Vaughn and team, and it's called the Statewide Quality Initiative to Reduce Unnecessary Antibiotic Treatment of Asymptomatic Bacteriuria. So this study is a part of a big quality improvement initiative called the Michigan Hospital Medicine Safety Consortium that was started in 2017. And the purpose of this is multifactorial, but really what they've been doing since 2017 is collecting data, sharing best practices, and benchmarking performance related to antibiotic treatment of asymptomatic bacteriuria. And so the problem that they were addressing with this study is that hospitalized patients with asymptomatic bacteriuria, which I'll just call ASB here, often receive unnecessary antibiotic treatment. And so they wanted to assess the outcomes of this quality initiative and estimate the effect of diagnostic versus antimicrobial stewardship. And that's what I think makes this study really interesting is not only are they looking at the outcomes of this large quality improvement intervention for the use of urines, but they're looking at if diagnostic or antimicrobial stewardship has a greater impact over the other. This is a prospective quality improvement project over 3 years. It included 46 hospitals between July 1st, 2017 and March 31st, 2020. It included hospitalized general care medicine patients with a positive urine culture, and the primary outcomes of interest were overall improvement in antibiotic use related to ASB, effect specifically of diagnostic stewardship. So this was measured as a change in percent of patients with a positive urine culture who also had ASB, and then the overall effect of antimicrobial stewardship. So this was measured as a change in percent of patients with ASB who received antibiotics, and then they looked at the total duration of those antibiotics. This is a nice table that they provide to help you understand those outcomes a bit better because they were a little bit confusing, I think, at first pass. The overall ASB-related use metric that's on the top there was calculated as asymptomatic bacteria that was treated divided by the total number of urine cultures that were treated. That diagnostic stewardship metric was really the total number of ASB divided by positive urine cultures. And the way they defined this was based on the fact that they only sampled patients with a positive urine culture. So patients with asymptomatic bacteriuria didn't enter the cohort when a urine culture was not collected. So this was a way for them to really monitor what was happening. And they said, you know, the percent of positive urine cultures that were also asymptomatic bacteriuria would decrease over time if diagnostic stewardship was working. And then that final metric was antimicrobial stewardship impact. And that was ASB treated with antibiotics divided by the total number of ASB cases. Okay, so overall, after exclusions, there were 14,572 patients. 28% of them had asymptomatic bacteriuria. Approximately 77% of patients with asymptomatic bacteriuria received antibiotics. After they did some statistical adjustment, the overall antibiotic use related to asymptomatic bacteria decreased from 29% to 17%. So at this point, they're saying there's a decrease in antimicrobial use related to this condition, but we're not sure what's driving that. So then in additional analysis, they saw that the percent of patients with a positive urine culture who also had ASB declined from 34% to 22%, but the percent of patients with ASB treated with antibiotics remained stable. And so really to them, this demonstrated that this decrease in use of testing was probably the thing that was driving this decrease in antimicrobial use. And so their conclusions here are that diagnostic stewardship may improve asymptomatic bacteriuria-related antibiotic use more than antibiotic stewardship. And I think that that's really powerful and speaks to the impact of diagnostic stewardship as not only, complementary to antimicrobial stewardship, but perhaps sometimes more of a driver of antimicrobial stewardship metrics than antimicrobial stewardship alone. Strategies to reduce unnecessary urine cultures resulted in most of the reduction in overall ASB-related antibiotic use, and they recommend that hospitals and national policy prioritize reducing unnecessary urine cultures to reduce ASB-related antibiotic use. The next study was published in Antimicrobial Stewardship and Healthcare Epidemiology. It's led by Dr. Marissa Winkler and team. I believe this was out of Boston, and it's called If You Don't Test, They Will Not Treat, Impact of Stopping Preoperative Screening for Asymptomatic Bacteriuria. The medical problem they were addressing here is that screening for asymptomatic bacteriuria is not recommended outside of patients undergoing invasive urological procedures and during pregnancy, yet we still see it happening all the time. This use is pretty rampant. Typically, it's just a part of an order set that is done for every patient getting surgery, regardless of what the surgery is. And so the aim of this study was to assess the impact of modifying cardiac preoperative testing checklist by removing the option for routine urinalysis and culture completely from that checklist. This was done at Massachusetts General Hospital, which is a 1,063-bed tertiary care facility in Boston, Massachusetts. The implementation of this intervention was done over several different time periods. So the first thing that they did was host an educational session in November of 2021 that was led by the study researchers and targeted cardiac surgery leadership. So the point of this educational session was to introduce the intervention, tell everyone that routine urinalysis and culture were going to be removed from the checklist, and provide information and evidence as to why this might be a good idea. The pre-intervention period is between May 2021 and November 2021. And that included the updating of the checklist, so actually removing the culture orders from the checklist and allowing for this wash-in period for people to adjust to this change, get used to it, and start normalizing it before they collected post-intervention data. And then the post-intervention was between December 2021 and May 2022. It's interesting to note that the Massachusetts General Hospital Microbiology Lab did not offer urine refluxing at the time. So pretty much everyone that received a urinalysis also received a culture at the same time. And this wasn't always true, but the numbers are pretty similar. There also was no decision support built into the electronic medical record at the time that required symptom attestation at the time of ordering. So clinicians really could order them whenever they wanted. And there was no sort of pop-up or anything in the computer system when they ordered. The primary outcome of interest was collection of a preoperative urinalysis within 30 days prior to an operation. They also did chart review to look for reasons for urinalysis and culture, results of these tests, and then antibiotics that were prescribed. Secondary outcomes of interest were surgical site infections, CLABSIs, CODIs, and C. diff infection within 30 or 90 days, according to NHSN criteria. And they also looked at laboratory costs. So this figure shows you a really impactful change there. You see a big drop in use by just looking at this image. But in total, 502 patients underwent 502 procedures between May 2021 and June 2022. 254 patients were in the pre-intervention group and 248 patients were in the post-intervention group. Patients were, their characteristics were similar in the pre and post-intervention group. Before the intervention, 97.2% of patients had urinalysis performed and 92.9% had a culture. And after the intervention, only 23.4% of patients had a urinalysis performed, which was a reduction of nearly 77%. There were 190 fewer urinalyses done in the post-intervention period, 205 fewer cultures, and they noted a cumulative savings of over $8,000. They also did not see any significant increase in those secondary outcomes of interest. So central line associated bloodstream infections or catheter associated urinary tract infections. They noted that removal of urinalysis and urine culture from preoperative checklists for cardiac surgery led to a statistically significant decrease in testing without an increase in any unwanted, unintended consequences. Challenges identified included persistence of checklists and templated order sets in the electronic health record. So they noted that even though they did this intervention and they did education, there were still unnecessary urinalysis and culture orders being performed, and that may have been due to the availability of these order sets in the electronic health record. So people were bypassing this checklist and finding other ways to order them. And so that's something to consider if thinking about an intervention like this. Significant inappropriate use remained outside of preoperative screening. And so I think in the future, they were considering applying the methods they'd done for these cardiac surgery patients to a broader group of people and seeing if they could improve urine culture use. Okay, we're going to move on to respiratory testing, which is my favorite topic. This one was published in Infection Control and Hospital Epidemiology. This is from Dr. Nathaniel Soper and Owen Album. It's called Healthcare Providers Consistently Overestimate the Diagnostic Probability of Ventilator-Associated Pneumonia. If you're familiar with the literature in this space at all, this study will seem very familiar to a study that was published by Dr. Daniel Morgan and team several years ago, where they looked at clinicians' ability to estimate disease probabilities at different stages of diagnosis or testing. And this is really similar to that study, except they're focusing in specifically on respiratory testing, whereas that other study looked at all sorts of things, including respiratory testing. The medical problem that they're addressing with this study is that the treatment of ventilator-associated pneumonia is often based on estimates of diagnostic likelihood, and honestly, we're not very good at that. We're just not good at estimating probability of disease or doing Bayesian statistics in our head. The point of this study was to assess the accuracy of ICU practitioner estimates of ventilator-associated pneumonia diagnostic probability before and after cardinal VAP clinical changes and VAP diagnostic test results relative to evidence-based estimates of VAP diagnostic probability. So in simpler terms, they basically asked clinicians questions about cardinal signs and symptoms of VAP at different stages of diagnosis, and then compared their estimates of probability to known estimates from the literature. This is a single center survey of ICU providers at Michigan Medicine University Hospital, which is a tertiary care center with 7 ICUs and 108 ICU beds. The respondents were clinical faculty and house staff at University of Michigan. It was sent to over 509 providers. And the survey included 5 clinical vignettes that were given in succession, describing ventilated patients with new isolated cardinal ventilator-associated pneumonia clinical changes, followed by a diagnostic test. They estimated baseline probability and then clinician's pre-test probability. And then after the clinician was given a diagnostic test result, they estimated post-test probability. And they compared these estimates to evidence-based likelihood ratios and probabilities from the literature. This is a really lovely figure that shows you exactly what they found. So overall, they had 133 survey responses. This was a response rate of 26%. At the top there, you see the baseline diagnostic probability estimates. This was based off of provider estimates of ventilator-associated pneumonia prevalence for a standard patient on a vent for more than 48 hours. And these estimates were consistently higher than evidence-based baseline estimates from the literature. And so you can see there in the figure, the provider estimated probabilities are in blue and the evidence-based probability range is in red. So consistently higher than that red range. If you go down to the second row there, you see the estimates for pretest probability, which was estimated probability of disease after the development of that cardinal clinical change, but before a diagnostic test was given or the result from a diagnostic test was given. And these estimates were consistently higher than the available evidence as well. And so you see the individual cardinal changes listed there, fever, purulent endotracheal secretions, leukocytosis, hypoxemia, and increased non-purulent endotracheal secretions. And all of those had consistently higher evidence or estimates than the evidence. And then in the bottom row there, you see the post-test probability, which is the estimated probability of disease following ventilator-associated pneumonia diagnostic test result. And again, those estimates were consistently higher than what was available in the evidence. And they also noted that attending physicians were far less likely to overestimate the burden of disease than trainees, and they noted that that may be an area for education. This is another great figure that walks through some imputed likelihood ratios that were calculated from respondent pre-test and post-test probabilities. And again, it's showing very similar trends here. The evidence-based likelihood ratios are the red diamonds, and the provider estimated likelihood ratios are the blue circles. And for the most part, the provider estimated likelihood ratios were higher than what was available in the evidence. The only time it was lower was when the clinician had a positive mini BAL gram stain. So I thought that was really interesting. Their conclusions and key takeaways are that practitioners consistently overestimate the likelihood of disease, both at baseline and then in response to clinical changes and test results. So it's like this slippery slope. For ventilator-associated pneumonia, overestimating this diagnostic probability after a patient develops an isolated cardinal change then leads to testing, and then the results of that testing are overestimated, and all of this leads to excessive or unnecessary antibiotic use. So their point is that misinterpretation of cardinal signs and test results suggests that diagnostic stewardship in the pre-analytic phase could be effective. So this is like early on in the testing process, potentially before a test is even ordered, making sure the test is not ordered when it's not needed may be the most impactful intervention here. The improved performance of attending physicians relative to trainees is suggestive of the benefits of additional education and experience in accurately diagnosing VAP. So potentially maybe an area for additional education or training. We're going to move into stool testing. This study comes from the American Journal of Infection Control, led by Dr. Charles Bussell and team, and it's called Implementation of a Multidisciplinary Process to Improve Diagnostic Stewardship of Hospital Onset Clostridioides difficile Infections. And so really the problem they were trying to solve here is that they saw a lot of what they felt were false positive diagnoses of hospital-acquired C. diff infection, and they wanted to see if they could use diagnostic stewardship to reduce the amount of testing on inappropriate specimens and thereby reduce the rate of false positives. They had a great graphical abstract here, so I thought I would just share that, and we'll just walk through this together. This was a retrospective analysis on inpatients over the age of 18 who were admitted to Baylor Scott and White Medical Center in Texas. This is a 640-bed tertiary care academic hospital. They established a baseline rate first of hospital-acquired C. diff from January 1st, 2017 to June 30th, 2017. It's also important to note at the time, the only testing that was used for C. diff was PCR. And then they started working on creating some improvement measures and putting those into place. And so this started with multiple policies and procedures to guide appropriate C. diff testing, but ultimately they created this algorithm that was refined into a checklist that they named this ticket to test, which is what you see at the top there. And if you look in the middle of this picture, you'll see some of the things that were included on this checklist. This checklist had to be filled out by a clinician when they were ordering a C. diff test. It included things like questions about symptoms, whether the patient had been on laxatives, had an enema, had stool softeners, did they recently have a lab test for C. diff. They had to fill all this out, and then they had to sign that sheet. And that ticket or that sheet had to come with the specimen to the microbiology laboratory. The microbiology laboratory would verify that the checklist was completed and that the stool was conforming to the shape of the container, so was liquid enough to warrant C. diff testing. And if not, they were empowered to reject the sample and do nothing else with it. The authors also noted that the nursing staff was empowered to reject the specimen at the time of collection if that checklist was not filled out appropriately. They noted that there was a really significant change in appropriate stool sampling or stool samples sent for C. diff testing. So the appropriateness went from 53% to 81% after this intervention was put into place. And they also noted a reduced false positive diagnosis of hospital onset C. diff cases from 9.5 cases a month down to 5.3. Their conclusions and key takeaways here is that a physical card used in this intervention was kind of labor intensive, but had really high impact. And I thought that this was an important one to showcase for sites that may not have things built in the electronic medical record, where maybe paper is still being used or cards like this may be a more feasible option. It was a really high impact initiative. And although it maybe isn't ideal for reducing waste, it makes for more paper, it could be a really useful and potentially easy to use tool. Consider incorporating the same checklist into electronic medical records if this is an option for you. And they noted that future research should potentially look at whether the differences between using a card or the electronic medical record are significant. They said implementing specific protocols involving multiple disciplines within a hospital system can improve the appropriateness of stool sampling and testing. And this was a great example of collaboration between multiple teams in the hospital setting, including the clinical staff and the microbiology laboratory. All right, now we are going to move into top papers in microbiology. This is also very challenging, lots to cover here, but we're going to do our best. So the first thing I want to touch on is bacterial nomenclature. I will tell you, if you are not familiar with what's happening in the area of nomenclature and taxonomy and clinical microbiology, I highly recommend that you get familiar with this. This is something that is not only going to impact microbiology laboratories or is impacting microbiology laboratories very significantly, but it will absolutely also impact clinical practice. And so while I'm not going to walk through these, the specifics of these papers in great detail, I want to make sure you're aware of them and that you have a chance to review them later if it's of interest to you. The first paper on the top there was one that I was invited to write for Open Forum Infectious Diseases with my colleague and friend, Dr. Nick Moore from Rush Medical Center in Chicago. And this is called Change of Plans, Overview of Bacterial Taxonomy, Recent Changes of Medical Importance and Potential Areas of Impact. And what we tried to do with this paper, it's a narrative review. What we tried to do was not only include examples of recent changes to taxonomy, but also tie this to antimicrobial stewardship and what kind of impacts taxonomy changes have on clinicians and stewards, as well as the microbiology lab. So we've got some clinical examples in there. We tie things to the CDC core elements for stewardship. Might be worth checking out if you're unfamiliar with nomenclature. On the bottom, this paper, if you're not confused, you're not paying attention, Ochrobacterium is not Brucella. This provides a very specific example of a recent change that has occurred that has tremendous impact on infection prevention, microbiology, infectious disease, management of patients, et cetera, et cetera, et cetera. It's really impactful. It's really important. And this paper really dives into that specifically and talks about all the logistics and recommendations for what you should do to handle that name change in the laboratory or in practice. I've also added 2 papers on fungal nomenclature. Bacterial nomenclature is not handled necessarily the same way as fungal nomenclature. Fungal nomenclature has a bit more, in my opinion, a bit more of a structure to it, more of a framework to follow. And there are a lot of changes. So these these papers are excellent for familiarizing yourself with the changes that have happened recently. They're really comprehensive, and they will help you to understand how and why these changes are made. That top paper there, the fungal nomenclature is the name of the game, managing change is the name of the game. That covers clinically relevant changes made over the last 20 years. So it's really comprehensive. I'm a microbiologist, and I cannot remember these name changes for the life of me. So I consistently refer to these papers to try to make sure I'm using the most current forms of Candida or whatever else has changed recently. In that bottom paper, there is this conceptual framework that was put out by several scientific committees for how these changes should occur. And so it's pretty dense, but I think it's an important thing to familiarize yourself with, just so you understand how these changes are happening, and why all of a sudden one day a report may look very different for an organism than you're familiar with. I added this paper per request, and I was humbled and honored to add it. Happy to do so. This is a paper that I wrote with some colleagues here in the US called AMR Rounds, a systematic educational approach for navigating bench to bedside antimicrobial resistance. And this was published in JAC Antimicrobial Resistance. This is an initiative led by Dr. William Wright, who's based out of Johns Hopkins. And it comes from a program that he developed at his facility that ties together antimicrobial stewardship education and training with clinical microbiology, and then also the training of fellows and other medical trainees. And while it started as an educational initiative, it has sort of morphed into more than that. And that's what we cover in this paper. Like I said, this was a program developed by Dr. William Wright as a standardized systematic approach to addressing AMR within the context of a larger stewardship program at Johns Hopkins. And so the idea was to think about ways to get trainees to think about AMR and apply it to clinical practice in a very stepwise approach. And I think we're finding that even though this, again, is an educational tool, this actually is very clinically applicable and could be helpful if you walk through this in your mind as you're thinking about your diagnosis and then management of a patient. And so what we do in this paper is we walk through 5 steps. The first step is collaborating with the clinical microbiology lab to confirm that organism identity and antimicrobial susceptibility test methods. And in this section, we walk through what interpretive reporting is. So looking at the results that come off of an automated susceptibility test system or otherwise, and looking at that pattern and seeing if you can deduce any information about the organism and its resistance pattern. And then also talking and working with your laboratory and seeing what sort of confirmatory testing they're doing for various resistance mechanisms. We have a table in the paper that walks through the pros and cons of confirmatory testing for various resistance mechanisms, as well as using interpretive reporting instead of doing confirmatory testing. Step 2 is to acknowledge bacterial specific mechanisms of intrinsic resistance. There's a nice table in the paper that walks through the intrinsic resistance mechanisms of some common organisms. Again, this is not meant to be super comprehensive. It's really touching on the most common organisms and mechanisms, just to really illustrate the example of using this framework, but it is still useful. Step 3 is to review local, regional, and geographical epidemiology of AMR. We've got some information in the paper about national and global programs for AMR surveillance, as well as using local antibiograms to guide your management. Step 4 is understanding acquired resistance mechanisms and interpretive antibiogram reading. And we've got a table that's got all sorts of resistance mechanisms in there. And then step 5 is putting it all together to treat a clinically relevant infection. And within the paper, step 5 walks you through some of those clinical decision-making points with a real-life example. These are just examples of some of the figures from the paper. So overall, we felt that this is a useful, comprehensive, and standardized approach to addressing AMR within the context of antimicrobial stewardship. This new scheme could be a foundation for mechanistic phenotypes that could help facilitate clinical reasoning and enhance comparability among clinical studies that inform care. And, in the future, maybe we try implementing this and looking at effectiveness of these principles to further explore the accuracy of this approach and see if more generalizable conclusions about how this type of education impacts clinical care. So I've gotten a lot of great feedback about this paper. Dr. Bill Wright is wonderful, and I think he's done a great thing here, and he continues to lead the AMR Rounds initiative. So if you're on social media, you'll continue to see more AMR Rounds things popping up in the near future here. This paper focuses on susceptibility testing, which is my other favorite area to talk about. This one was published in the Journal of Clinical Microbiology by Martin Serink and team, and it's called Less is More: When to Repeat Antimicrobial Susceptibility Testing. The medical issue they were tackling here is that there's no standard for optimal frequency of repeat susceptibility testing. I love this paper because there are a lot of things we do in clinical microbiology that have just always been the way we've done things. Sometimes there's a lot of evidence to back up the practices that happen in the lab, and sometimes there's like a little bit of evidence and it's really old and we haven't revisited it. That's sort of what this paper is about. It's standard practice in most medical laboratories to repeat susceptibility testing within 2 to 5 days on an isolate, but there's really not a lot of evidence to support that. And so they wanted to look at this just in terms of reducing waste, but also, potentially doing some diagnostic stewardship here and reducing excessive testing. So they wanted to investigate the frequency and timing of the change of the susceptibility pattern between isolates cultured from the same patient. They did note that this is not research into clonal changes or anything like that. They're really looking at phenotypic susceptibility patterns over time and making some assumptions there. This was a retrospective observational study using laboratory data from Erasmus University Medical Center in Rotterdam. This is a tertiary hospital with over 1,300 beds, and the data were collected over a period of 8 years. The data types that they collected, or this information they collected, were on sample types, anatomical origin, isolation date, isolate identification, and then raw MIC results from automated antimicrobial susceptibility testing, or AST. The organisms that they looked at were E. coli, Klebsiella pneumoniae, Enterobacter species, Pseudomonas aeruginosa, and Staph aureus. They have several important definitions in here. The first is paired isolates. Paired isolates were considered two organisms with a similar ID that came from different anatomical sites on a patient from the same day. So urine and blood, or a wound and blood, different sites, but the same organism from the same patient. Successive isolates were considered two organisms with a similar ID that were cultured from the same patient at two different time points. So the patient had this organism on day 1 of hospitalization, and then they grew it again on day 4 or something like that. They calculated categorical and essential agreement, which we've abbreviated here as CA and EA, of paired and successive isolates according to CLSI guidelines, or Clinical and Laboratory Standards Institute. Essential MIC increase is a term that they created for this paper, which they defined as an MIC increase of 2 doubling dilutions over time in successive isolates. A change from non-resistant to resistant is something else they also created for this paper, which is a change from a non-resistant isolate to resistant over time in successive isolates. And then they looked at the data from these and put it in the context of the idea that resistance percentage up to 10% is considered an acceptable threshold to use for empiric treatment. So essentially anything that was 10% or less in terms of resistance was considered acceptable, if you will. The first thing they looked at here was the essential and categorical agreement of any antibiotic of 2 isolates with the same identification from the same patient, isolated on the same day, to just see how similar these really are. And they found that the agreement was really excellent. It was a bit lower for gram negatives, and the authors thought maybe this is because more drugs were tested for E. coli and Klebsiella pneumoniae, but it was really high for Staph aureus. There's a lot going on in this table, so I'm just going to highlight a few parts here. The study showed overall that the change in the susceptibility testing pattern occurred during a median time of 12 days. So if something was going to jump over 10% resistance, it usually happened after 12 days for most organisms. If you look at that Staph aureus section there, you see all the performance characteristics broken down by groupings of periods of time. So 1 to 7 days, 8 to 30 days, and then 31 to 365 days. The essential MIC increase categorical change from non-resistant to resistant, and then combination of those two things are seen as the three bottom elements there. And for Staph aureus, you see nothing gets up to 10% until after 30 days. For the gram-negative, so for E. coli, Klebsiella pneumoniae, and Enterobacter, everything hung under 10% up to 7 days. And Pseudomonas was actually quite different. The risk of resistance was actually higher than 10% between 1 to 7 days. So that one looked like it was more likely to be resistant as compared to those other bugs. They also did some additional analysis using that really strict criteria, combining the two parameters. So categorical change from non-resistant to resistant and an MIC change of more than one doubling dilution, and then broke it down by drugs or drug category, if you will. A risk of a repeated culture with Staph aureus that was resistant was low across all antibiotics. So the risk of this happening in Staph aureus just across the board is really low. For E. coli and Klebsiella pneumoniae, the proportion was highest for amoxicillin clavulanate, cefuroxime, ciprofloxacin, and Bactrim. And then for Pseudomonas aeruginosa and Enterobacter species, the risk was highest for Piptazo and ciprofloxacin. And so their key takeaways here is that if we accept that a change in susceptibility pattern from non-resistant to resistant occurs in less than 10% of these isolates for any routinely tested antibiotic, and a culture shows the same organism as before, in the case of the organisms that they tested in this study, with 7 days or less between those two cultures, repeat susceptibility testing could be omitted from that second culture. And so for labs where multiple types of specimens are taken on the same day and are processed on the same bench, this could be considered a really great way to save time, money, and reduce laboratory waste. So this was a really interesting study. It's one you're going to have to go back to and read. It's pretty dense, but very interesting and potentially really helpful for labs that are doing a lot of extra work that they may not need to do. Speaking of blood cultures and susceptibility testing, I do want to give some honorable mentions to these two studies here, which are highlighting some great new technology we're seeing come to market in terms of rapid phenotypic susceptibility testing. The top one there looks at the A-STAR device from Q-linea, which is rapid susceptibility testing direct from blood cultures. The study showed that comparison between the A-STAR and the reference method revealed an overall essential agreement of 95.8% and a categorical agreement of 97.6%, with a turnaround time anywhere between 3 to 6 hours. So really great performance there. Very interesting. That study comes out of Sweden. The bottom one there is from Henry Ford Hospital in Detroit, in the United States. This one looks at the Vitek Reveal Rapid Susceptibility Test System, which is also direct from blood cultures. The Reveal AST results versus Sensititer had an essential agreement of 98%, categorical agreement of 96%. Also very high when they compared to Vitek 2, and also they had very low minor errors, major errors, or very major errors overall, with an average turnaround time of 4.6 hours. So these are some great options. There's a lot happening in this space, so keep your eye out for more rapid phenotypic susceptibility testing options. I'm not going to dive into this one very deeply, but I did want to highlight it. It is one of the most cited articles in the Journal of Clinical Microbiology from 2023. It's very comprehensive and honestly very relevant given the rise in cases we've seen in syphilis over the last few years. Sorry to take a sip of my coffee. I think too, the laboratory diagnosis of syphilis is really complex. And so this is a great way to get up to speed with all the options that are currently available and a review of if anything's changed over the years. They give lots of great information in here about disease state, different types of manifestations of syphilis, and then a great table like this where they walk through the different types of syphilis testing as well as performance across primary, secondary, early latent, and late stages of infection, latent stages of infection. And then they also provide lots of references that you can dig into if this is something you're interested in. The key takeaways from this paper are that far and wide, the laboratory diagnosis of syphilis remains predominantly serological. So in a time when we're seeing a lot of molecular testing come to market for pretty much every disease we can think of, right now, serology really still is the test of choice for syphilis. It suggested that 2 treponemal assays be initially used to confirm the presence of syphilis. Clinical and epidemiologic context must always be considered with results, as is true with all of our tests. And point of care tests are available, but they're best used for screening in high prevalence populations with limited diagnostic facilities. And I thought the section on point of care testing was interesting in there and probably something everyone should take a peek at. And then finally, molecular testing does not replace serology. It definitely has utility in the space of like congenital syphilis, for example, but overall molecular testing does not replace serology at this time. This study falls into the category of diagnostic test comparison, which is also a topic I love and absolutely don't have enough time to really get on my soapbox about today. But this study is a really, really interesting study published in Journal of Clinical Microbiology. It was editor's pick, and it's called Comparison of 3 Rapid Diagnostic Tests for Bloodstream Infections Using Benefit Risk Evaluation Framework, or BEDFRAME. The medical problem they're addressing here is that traditional statistics for evaluating different diagnostic methods do not include local epidemiology and provider preferences. So if you work in the lab and you think about any time you've wanted to bring testing into your facility and you're comparing performance characteristics, never are we including information about epidemiology or provider preferences in choosing a diagnostic test. And this actually can be exceptionally important when we think about implementation and use. So what they wanted to do was evaluate the performance of flat MS. Flat MS is a technique they're using at this center called fast lipid analysis technique, I think. Yes, flat lipid analysis technique. This is something you can do on MALDI-TOF. They wanted to look at the performance of that in identifying pathogens directly from blood cultures compared to its performance from FDA-cleared rapid diagnostic tests for identification. They used the BEDFRAME framework to compare the performance of these tests as well as, which one they might want to implement. They used 301 blood cultures from adult patients aged 18 years or greater at the University of Maryland Medical Center from September 2021 to August 2022. They compared this flat methodology versus the Bruker sepsititer versus the FilmArray BCID2 panel. They did do the traditional evaluations. They collected data on sensitivity, time to results, and hands-on time, but then they also incorporated this BEDFRAME recommendation to do the full analysis. BEDFRAME is a framework that was developed by the Antimicrobial Resistance Leadership Group, or ARLG. And though it's been around for a while, the authors made a note that they really haven't seen it applied to actual clinical data yet. And so this is a proof of concept study. The steps for BEDFRAME, which I'll list here and walk through quickly, I really recommend you take a look at this paper. It's very interesting, is to first make a plot displaying expected yield of the test as a function of prevalence. So this helps communicate that potential clinical impact of the test. Then plot the expected diagnostic difference. For this study, they're looking at the difference in unidentified gram-negative bacteria and accurately identified gram-positive bacteria as a function of prevalence using the calculations they got from step 1. Then calculate the number needed to treat. So number needed to treat is the number of patients positive for a disease that must be tested with one test relative to another to result in one additional true positive. Then plot weighted accuracy as a function of relative importance. Relative importance is a little subjective. There's a few ways you can get at this, but typically this involves some qualitative data about clinician preferences or things you can get from delivering a survey. And that's what they did here. They determined this via a survey to key stakeholders. And then display the difference in weighted accuracy as a function of relative importance and prevalence. So lots of plots, lots of great figures in this paper. This is an example of one of them. This is showing the expected diagnostic yield as a function of the prevalence of gram-positive bacteria for a fixed population of 1,000 positive blood cultures. And so they'll show you the different test methodologies in A, B, and C. And the red represents identified gram-positive bacteria. That gray space is identified gram-negative bacteria, and then the blue and that greenish yellow color represent the things that were unidentified. So just from looking at this, you can get a quick picture of which one is going to identify the most organisms, the best from positive blood cultures. And you can see that overall these look like they're pretty similar in performance. And they noted that in the study. They said really the performance of these tests were really similar, and that's where the additional context that comes from bed frame is helpful in deciding which tests to pick. And that's what this figure shows here. So tests had similar accuracies and time to results, and they all performed well. Sepsityper had more hands-on time, but really the performance was the same. And so then they incorporated the data from the surveys to clinicians that accounted for their preferences or things they would hope to see from a test. They incorporated local epidemiology data, and this is what they got. So you see here, let me see if I can get this right. The blue area there indicates combinations of relative importance and prevalence where sepsityper is favored. Okay, so that's the multi-tall sepsityper there. The gray is where flat MS is favored. And then that gold is where BCID2 is favored. The lines, the black lines are where the tests are all really similar. And then that A with a dot is where this medical center fell when they included all of the preference and epidemiologic data. So this tells them that, you know, based on all the information from their center, this BCID2 might be the better choice for them in their local setting. So the use of a survey in combination with bed frame in this study provides a streamlined framework for other healthcare settings deciding between diagnostic tests. They considered this a successful proof of concept of the use of this bed frame framework. One important thing to note is that it doesn't consider important components such as time and cost. And so, you know, BCID2 might be much more expensive than their flat technique. And so if they had considered cost, maybe that little dot with the A on it may have moved somewhere else in the figure. I'm not sure. So they said, you know, this is something important to consider. But overall, this framework is really helpful in choosing between diagnostic methodologies. I think it's a really interesting approach, and I think it's probably something we're going to start seeing a lot more in microbiology and diagnostic stewardship. So I would keep an eye out for that and maybe familiarize yourself with that framework. And then the final study is just a quick mention, one that's hot off the press. This was just published a week or two ago. This is in Journal of Clinical Microbiology under antimicrobial chemotherapy. And this comes from Dr. Joseph Cuddy's group. And it's called Effects of Clinically Achievable Pulmonary Antibiotic Concentrations in the Recovery of Bacteria, in vitro comparison of the BioFire film array pneumonia panel versus conventional culture methods in bronchial alveolar lavage fluid. Long title there, but essentially what happens is they did this great in-laboratory study where they looked at various concentrations of organisms and essentially spiked samples with organisms and varying levels of antibiotics. They mimicked epithelial lining fluid peak and trough concentrations. They did a bunch of great calculations, and they demonstrated what the yields may look like using different testing methodologies. And ultimately, they found that this PCR panel is able to identify gram-negative pathogens in the presence of clinically significant antibiotic concentrations when culture methods may not. And so this is a really interesting piece in just applying some really rigorous data to something I think all of us are already aware of. But it's really important for us to consider the impact of pre-treatment on specimens before we do any testing. And so this is a really nice paper that pulls in some great data that helps explain that a bit better. Okay, and I'm going to stop there. I'm happy to take some questions. I'll hand it back to my moderators, but I like to leave this information up for a little bit. If you ever would like to reach out to discuss anything or have additional questions, I'm happy to chat at any time at those contacts listed on the screen. And I thank you so much for your time.
Thank you so much, Andrea, for an amazing session. So we have one question for you today. So is there any implementation of a digital form in medical records in US hospitals before sending a bacterial culture to rule out asymptomatic bacteriuria before a urological procedures as a part of diagnostic stewardship? Because in India, we do not have this. So we wanted to know, like, is this is a common practice in US hospital or not? What is the current scenario there?
You know, and so you're specifically asking about electronic screening for preoperative.
Yeah, yes.
You know, I don't know that I would say common. I don't know the literature quite as well in the preoperative screening space, but I do know that it's variable across settings. So there is a ton of variability in who reflexes urine cultures, who orders pan cultures before surgery or not, who builds things in the electronic medical record or not. I don't know that I would say that it's common. I would say it happens. There are larger academic medical centers that are doing this, like kind of a clinical decision support system. But I can't tell you exactly how prevalent it is. There is another study. I'm looking for it right now in my pile of papers. I almost included it, but I didn't have enough time. Um, and I would recommend it to everyone if you're interested in urine cultures. It's a paper published in Open Forum Infectious Diseases about electronic clinical decision support systems for urinary tract infections or asymptomatic bacteriuria. And so it's a great review of what's available, what studies have been publishing on these clinical support systems. And they found that the data are really mixed. And whether or not these are having an impact or being used widely is sort of unclear at this time. So I know that's not a clear answer, but I would not say it's common per se. And I can look into some data if that's helpful and see what the prevalence is, but I'm not entirely sure.
Okay, okay. Thank you so much. Thank you so much. So, another question we have just got. What do you think is the most misused or overdiagnosed culture sample, like urine, respiratory, or stool?
So I'm very biased. I'm very biased here. All of my research is in respiratory culture, diagnostic stewardship. So I think respiratory cultures are the hardest and the most abused, if you will. But I will tell you, I think the biggest target area is urine because so many urines are collected, right? Like that is one of the most common reasons why people seek medical care is for suspicion of UTI. So just by sheer volume of specimen, it's probably urine. Although I would say that respiratory cultures are truly the one of the most significant drivers of excessive antimicrobial use in the ICU. So in the ICU setting, I would say respiratory cultures. In the overall population, I would probably say urine.
Okay, thank you. Thank you so much for an insight. So I will end this session with two announcements. So I would just like to share my screen.
Okay, let me stop here.
So So as we bring this engaging webinar to a close, I'm delighted to share information about a significant upcoming event in the field of infectious diseases. So this ID conference scheduled from January 19 to 21 in Calicut promises to be convergence of leading minds in the realm of ID research and healthcare. This conference will serve as a dynamic platform for professionals to delve into diverse topics like exchanges, insights, and poster collaborations. From cutting-edge researchers' presentation to interactive discussion, the ID conference offers a comprehensive exploration of the challenges and advancement in the critical field. So we just have 3 days left for this conference. So if you haven't registered for it, please do it. So another building on the momentum from this conference, I'm thrilled to announce another enriching opportunity on January 29th at 8 p.m. Indian Standard Time. Veena Ven Gopalan will lead an online webinar focusing on top papers in pharmacokinetics, PKPD, and therapeutic drug monitoring for antimicrobials. This webinar is a unique chance to delve into the latest advancements in antimicrobial pharmacology guided by the expert in the field. So before we conclude, let's express our sincere appreciation to our distinguished speaker, Dr. Andrea Pinzi, for sharing her invaluable insights and expertise today. Dr. Pinzi's contributions have not only enriched our understanding of clinical microbiology, but also have set the stage for further exploration in the infectious diseases. We extend our heartfelt thanks for her time, knowledge, and dedication to the advancing the field. Thank you so much.
Thank you so much. Happy holidays. Happy New Year.
Same to you. Same to you.